Assalamualaikum and a very good day. We are here in the series of basic point of care ultrasound in emergency, prepared by Emergency and Trauma Department, Hospital Kuala Lumpur. And we will be focusing on deep vein thrombosis. The objectives of this lecture is to learn the correct technique for image acquisition in DVT and to understand image interpretation of the artery and vein of the upper limb and lower limb. So we will be able to integrate the use of PoCUS in diagnosing DVT and PE. So here is the brief introduction of DVT. DVT is a medical condition that occurs when a blood clot forms in a deep vein. These clots usually develop in the lower limb, but they can also occur in the arm. The importance of diagnosing DVT is because it can lead to life-threatening event, which is pulmonary embolism. The indication to perform ultrasound in DVT is when patient is having unilateral limb swelling or pain, and in patients with suspected pulmonary embolism, looking for a source of embolus. From evidence-based study, it shows that PoCUS has 100% sensitivity, 95.8% specificity, 61.5% positive predictive value, and 100% negative predictive value. But why PoCUS is used as the first line in diagnosing DVT? This is because PoCUS is non-invasive with no radiation, so it is suitable for pregnant patients, whom also one of the high-risk groups in developing DVT. It is portable and can be done by the bedside. So we can do real-time visualization and also can help in unstable patient, which is not stable for transport to imaging department. It is also sensitive and specific to diagnose lower limb DVT. From the result of the ultrasound findings, we can do immediate clinical decision. Okay, so in this slide, it shows ultrasound enhanced well score in pulmonary embolism. This table is more objective as higher scoring is given based on evidence of positive findings of DVT and lung ultrasound, which can suggest pulmonary embolism, compared to non-specific signs and symptoms of DVT to come to the diagnosis of pulmonary embolism. In patients with suspected PE, point of care lung and venous ultrasound is feasible, rapid, and increases the accuracy of the conventional well score. However, integration with the D-dimer is still needed. A diagnostic strategy which integrates clinical information, lung and venous ultrasound, and D-dimer may increase the performance of risk stratification and may reduce the use of CTPA in diagnosing pulmonary embolism, but still maintaining an acceptable safety profile. So next, we will proceed with ultrasound of lower limb. First of all, we need to understand the basic anatomy of lower limb veins. Veins are divided into deep and superficial veins, and in between these two veins are called perforating vein, which drains blood from superficial into deep veins. The deep veins comprise of iliac vein, femoral vein, popliteal vein, and tibial vein, while the superficial vein consists of greater saphenous vein and lesser saphenous vein. In ultrasound DVT protocol, we need to choose the correct probe to get the best image acquisition. It is recommended to use the high or low frequency linear probe. Patient is put in supine, erect, or seated in reclined position, because the calf veins are easier to view when the legs are lower than the body, allowing some venous distension. Okay, we have to know that there are two modes that will be used in PoCUS for DVT. The first one is B mode, and the second one is color Doppler mode. In this slide, we will learn the differences between the artery and vein under ultrasound view. So artery is thick wall, muscular, and pulsatile when pressure applied, while veins have thin wall and flatten as pressure applied, and it has valves. The clips on the left shows the axial cut of the right IJV and carotid artery, while on the right, the clips shows the longitudinal views of the vessels. We can see in both clips, the carotid artery has thicker wall and pulsating, while the IJV is compressible and varies with respiration. However, valves are not visualized in the vein. The other mode can be used in assessing DVT is color Doppler mode. The clips both show color Doppler mode on common femoral artery and common femoral vein. You can see there is clear signal of color Doppler filling up the lumen in both arteries and vein. Now that we already know which probe to use, the correct positioning of the patient, and mode used in assessment of DVT, we will proceed with techniques of lower limb DVT ultrasound. We have three techniques. First is 2-point compression test. Second is the extended compression test. And the last one is the whole leg compression test. We can see in the figure, it shows the different area to be scanned on the lower limb. So we start with 2 points compression test. In this test, we scan at the groin and popliteal fossa. And with this scan, it reduced the time of scan by half, which is 54%. More than 99% of the proximal thrombi found with the limited compression approach, and the thrombosis detected by complete examination also detected in limited examination. While in extended compression, we scan from groin to popliteal fossa. Half of the time is safe because the visualization of calf vein is not required, as there is no significant thrombus that may arise from these veins. In whole leg compression, it is time consuming because we need to scan the whole leg from groin until calf. Even though it is time consuming, it provides more comprehensive information. Hence, it can reduce repeated attendance of the patient to the hospital, as we can identify alternative diagnosis if the results is negative for DVT. And again, the visualization of calf vein is not required. So we will spend more time doing whole leg compression tests, despite of no significant thrombus can arise from the calf vein. So overall, actually in this lecture, we will focus on 2-point compression test, which is more important in diagnosing DVT. So we start scanning at the inguinal region. Patient lying supine, and the hip must be slightly flexed and externally rotated. We place the probe just below the inguinal ligament at the femoral triangle, and then we can see the structures at the femoral triangle, which is common femoral vein and common femoral artery. So this is the scan from left femoral region. You can see the common femoral vein and common femoral artery. So how you identify the structure is by pressing down the probe. You can see that the common femoral vein is compressible, while the common femoral artery remains flattened. So this is the normal view of ultrasound of DVT. So we proceed with scan at popliteal region. On the right side of the slide, it shows the different position to scan the patient. We can choose to either put the patient in prone position, lateral-decubitus, or supine with knee slightly flexed. And we can also ask the patient to sit by the bed with the lower limb hanging down. So let's see the clips of scan at right popliteal region. When we apply pressure, we can see there is compressible structure, which is the popliteal vein, while the popliteal artery remains better. So I will share some tricks to scan at this region. As popliteal vein is superficial, it is easily compressible. Usually when we scan, the popliteal artery is visible, but the vein is readily compressed. So we just have to release the probe slightly to see the vein. Okay, just now we already learned how to identify the normal structure. Now we will learn what to look for in DVT. So in DVT, we will see there will be failure to compress veins, and there could be echogenic thrombus in the vessel and filling defect, which we can see in color Doppler mode. Tips in doing the 2 points compression test is to beware not to apply too much pressure until causing compression of the artery. We have to place the probe at the center of area of interest to ensure equal distribution of pressure. And another thing to remember, if blood pressure is low in hypovolemic patient, the vein and artery can both be collapsed. So let's see the clips. This is a clip showing the left popliteal region. We can see echogenic thrombus in the popliteal vein shown by the arrow. Okay. Oh, okay. So in this slide, there are two clips that shows how DVT looks like in ultrasound. The first clip on the left is a clip at the left inguinal region. We can see there is echogenic thrombus in the common femoral vein, causing failure to compress the vein. And the greater saphenous vein is partially visualized and appears not compressible. On the right is a clip at the left popliteal region, and we can see the popliteal vein is not compressible with echogenic thrombus intraluminally. Okay, so this is B mode that shows the appearance of thrombus during ultrasound, because thrombus can appear in anechoic, so sometimes it is not visible using B mode. So we can see in this slide, the left side it shows the inguinal region under B mode. It shows there is echogenic thrombus in the common femoral vein, while the femoral arteries is pulsating. So we can see the differences in the second clip where we use the color Doppler mode. We can see that the clot has caused a filling defect in the common femoral vein, while the color flow Doppler is still patent in the common femoral artery. Okay, that's all for lower limb ultrasound. Now we will continue with upper limb ultrasound for DVT. First, positioning. We put the patient seated and the upper limb in anatomical position with elbow slightly flexed. The superficial vein starts from basilic and cephalic vein, drains into median antebrachial vein, and then into the cephalic and basilic vein, into the axillary vein, and finally into the subclavian vein. For deep vein, it starts from ulnar and radial vein, into brachial vein, axillary vein, then into subclavian vein, brachiocephalic vein, and finally into external jugular vein. We will need to scan the upper limb vein from jugular vein to subclavian vein, then axillary vein, upper arm vein, then to the forearm vein, because that is the normal flow lah. We examine the deep vein from the neck and brachiocephalic vein to the hand. Okay, at the jugular vein, the probe is placed at the base of the neck. We can see in the clips that the IJV in pre and post compression. So the IJV is compressible. Sometimes, if we cannot find the IJV, we can just ask the patient to puff their cheeks to help distend the neck veins. Now at the subclavian vein, we put the probe above and below the clavicle, scanning from the base of neck to infraclavicle. We can visualize the proximal and distal subclavian vein, but usually the mid subclavian vein will be obscured by the clavicle. Okay, to scan the axillary vein, put the probe at the axillary fold, and you can see the vein is accompanied by arteries. In the clip shows that the axillary vein is compressible, and you can also see the axillary artery remains patterned. Okay, at the upper arm vein, we have to identify the brachial vein and brachial artery. So as usual, the upper limb vein usually will be accompanied by arteries. So we put the probe at the mid arm, and we can see in the clip, you can see the brachial vein is accompanied by the brachial artery, and the veins are compressible. For the forearm vein, we will scan at the medial aspect of the forearm. So the radius and ulnar veins are very small. Sometimes we need to use color Doppler to locate the vessel. In the clip here shows the ulnar artery accompanying the ulnar vein, and we can see the vein is compressible. Okay, so this is one of the example of the thrombosis in the upper limb. The clips show upper limb DVT associated with PICC line complication. This is caused by the malposition of PICC line, which cause thrombosis of the IJV. In the transverse image, we can see the thrombosis is in the right IJV, and the thrombus is not compressible. In the longitudinal view, we can see there is thrombosis in the right IJV with mild echogenicity and irregularity of the surface. Color Doppler shows filling defect due to the presence of thrombosis. Okay, so we are coming towards the end of the lecture. We need to know that there are few limitations in doing ultrasound of DVT, especially in obese patients or those with severe edema. These conditions will limit the scan quality and resulting in only being able to exclude occlusive thrombi. And it can be limited in patients with open wounds or sutures. And we have to bear in mind there can be non-visualization of a small non-occlusive thrombi if it is less than 3 centimeters. And specifically at the mid-subclavian vein, we can miss a thrombosis as it can be obscured by the clavicle. Last but not least, take-home message. PoCUS in DVT will help in early diagnosis of DVT and pulmonary embolism. Hence, we are unable to initiate early treatment. It is also helpful in identifying the cause of shock, obstructive shock. Okay, so that is the end of our lecture. Thank you for listening. I hope all of us will benefit from this lecture and can apply the knowledge in managing our patient. Thank you.